So, are you able to see that?
Yes, sir.
So, describe the role of intraoperative echocardiography in clinical anesthesia. That is the question.
Yes, sir.
So, we can first start with saying uses of PE in clinical anesthesia. Transesophageal echocardiography has become a commonly used imaging modality in clinical anesthesia, including the cardiac operating theatre, but also in intensive care unit, in interventional suite, where nowadays we are performing a lot of TAVI and mitral valve replacement by the transarterial route. Where also this can be quite useful. It is not only for intraoperative use, it is for these are also the domains where anesthetists are involved. And as an outpatient procedure or as a monitoring or a rescue device in patients who have or expected to have unexplained hemodynamic instability. So these are all the anesthetic indications for using the TEE in anesthesia. Why TEE and not transthoracic echocardiography? He is able to provide excellent ultrasonic imaging compared to transthoracic because of the proximal location of the esophagus next to the heart and great vessels. And there is no interference with the lung grids and other things which as you see with the transthoracic. So with the probe is very close to the heart. In fact, it is a few millimeters away from the heart, so you get a better imaging when you use transesophageal echocardiography. And it is more practical than transthoracic during most surgeries, especially during cardiac surgeries where they open the chest or do even if you are doing a video assisted thoracoscopy procedure, the chest will not be available for transthoracic echocardiography. So in such situations, this is more logical, transesophageal echocardiography. And the development and the wide availability of real three-time dimensional echocardiography with the transesophageal has come into play, which guides complicated cardiac surgical procedures or catheter-based cardiac interventions like transaortic valve replacement. So in all these situations, the advanced improved real-time three-dimensional echocardiographies can be done by using the transesophageal echocardiography probe. And the Society of Cardiovascular Anesthesiologists and the American Society of Echocardiography guidelines updated in 2013. They have now an expanded 28 standard views as well as three-dimensional imaging designed for intraoperative as well as outside the operating room work. So you get a very expanded, detailed views of the heart and the great vessels by using the transesophageal echocardiography. Now, anatomical views that you can obtain are it is first passed inserted through the oropharynx into the esophagus, and the TE views are obtained with the probe located in the esophagus or in the stomach. You can keep it in the mid esophagus or you can advance it even into the stomach. So you have mainly four views, which I will tell you later. And the variety of structures that can be imaged are cardiac chambers, valves, lungs, liver, superior vena cava, inferior vena cava, hepatic vein, pulmonary arteries, aorta, and even the stomach. All these structures can be viewed. But one limitation is the left main bronchus disrupts the views of the aortic arch and proximal ascending aorta when you keep the probe in the upper esophagus and try to visualize them. Now, indications for the use of PE can be evaluation of acute aortic pathology, evaluation of prosthetic heart valve or paravalvular abscesses, all open heart valvular or thoracic aortic surgical procedures, CABG. Earlier, when it was introduced, it was mainly used for CABG to see after the coronary anastomosis. Sometimes the wall motion abnormality gets immediately corrected, especially in the acute setting when they do a CABG in acute coronary syndrome. The transesophageal echocardiography was very helpful to find out whether the ischemic segment, which is not akinetic or hypokinetic, starts picking up and becomes kinetic very fast. So that is an indication that the blood supply is restored and the muscle which was about to die has recovered. So CABG was very useful in that condition. And then catheter-based procedures and unexplained cardiac failure. These are all some of the indications. And also diagnosis of pulmonary embolism, confirmation of air embolism, especially in neurosurgical procedures, evaluation of pericardial effusion, evaluation of congenital cardiac diseases in the intraoperative period to locate how big the VSD is or how big the ASD is or how the anomalous venous drainage is happening. All the congenital anomalies can be clearly identified. Now, the contraindications. So, these are some of the indications for the use. Contraindications can be again divided into absolute and relative. The absolute contraindications, if the esophagus has got any pathology like ulceration or malignancy or active upper GI bleeding or recent upper GI surgery, poor airway control, uncooperative or unsedated patients. Of course, intraoperatively, most of the patients will be anesthetized and they will have a secure airway. But if it is being done during the induction period or in the pre-anesthetic induction time, then you may have to, if the patient is uncooperative, you should not do it. And the relative contraindications are severe cervical arthritis, symptomatic hiatal hernia, thoracoabdominal aneurysm, coagulopathy, esophageal cancer, or varices or diverticulum. Now, the complications of insertion of the PE can be oropharyngeal area complications, esophageal complications, or gastric complications. So the oropharyngeal, it can be laceration of the lip, injury to the tooth, tongue ulceration, pharyngeal injury, or vocal cord palsy or arrhythmias. Esophageal, it can cause after the surgery, dysphagia, odynophagia, esophagitis, times esophageal perforation, or Mallory-Weiss tear. And gastric complications are gastritis, stomach ulceration, compression of mediastinal structures. So these are the complications. Now, basic ways to adjust the probe are, these are the four positions. You can either insert the probe or withdraw the probe. You can rotate it backward and forward. You can anti-flex and retroflex. You can flex them to the right or left. So these are the four modes of adjustment of the probe. And relative depth and position of the probe are, depths can be related to the incisors. One is called the upper esophageal probe, where the probe goes up to 20 to 25 centimeters and present in the upper esophagus. The second is mid-esophageal, where it is inserted from 30 to 40. Then transgastric 40 to 45 and deep transgastric 45 to 50, where these two it enters the stomach. These two it remains in the esophagus. So four modes of adjustment, four depths of normal advancements. In the upper esophageal, what is the clinical utility? You can see the ascending aorta, arch pathology, atherosclerosis, aneurysms, and dissections. So it is mainly used for any aortic repair. And it can also give you an idea about the aortic cannulation in cardiopulmonary bypass procedures. If you have a difficult congenital anomaly in the heart, then when you place the aortic cannula, you can assess the position. Similarly, pulmonary artery catheter position also can be confirmed. Then coming to the mid-esophageal, where the probe goes little more lower down, you can assess the ventricular function, both global and regional, and intracardiac chamber masses like thrombus, tumor, air, or foreign bodies. And you can see the mitral and tricuspid valve movements and their function. And you can see congenital or acquired intra-atrial or ventricular septal defect evaluation can be done at the mid-esophageal level. So it is very easy. Upper esophagus, it will be almost lying at the arch of aorta. Here it goes down to the ventricular fin, and also you can assess the coronary sinus. The transgastric 40 to 40 centimeter, it is mainly the left and right ventricle, mitral valve, and tricuspid valve. Clinical utility is mitral valve evaluation, like a fish mouth view or pathology and pathophysiology. Similarly, tricuspid valve evaluation can be done, and basal left ventricular regional function can be assessed, and basal right ventricular regional function also can be assessed by transgastric view. And deep gastric anatomy images left ventricular and outflow tract interventricular septum, aortic valve, ascending aorta, left atrium, mitral and right ventricular pulmonic valve. All the structures can be seen by deep gastric view, and it is used in aortic valve or subaortic pathology and pathophysiology, mitral valve pathology and pathophysiology, left and right ventricular global function, as well as thrombus. What you saw again in the mid-esophageal, the same thing can be seen here also. So these are all the things that you can visualize. So for this answer, you start writing about the advantages of PEE, why you do that, then the indications, contraindications, and a simple method of showing your knowledge as to what are all the positions in which it can be kept and what are all the structures that can be visualized and be monitored intraoperatively. So that I think will give a wholesome answer for this particular question.